a male patient with 76 years old, represented with a typical pain of the upper abdominal with irradiation to the dorsal part. A CT scan showed a suspicious lesion of the tail of pancreas and also a thickening of both adrenal glands. MRI was performed with a hypervascular lesion of the tail of the pancreas with a suspicion of a neuroendocrine tumor. US evaluation showed a 2.2 centimeter hypoechoic nodular lesion located in the tail of pancreas, and no suspicion lymphadenopathy or alteration of adrenal glands were observed. So this is the images of MRI, as we can see, and also elastography shows a stiff tissue, as we can see. So this examination will perform with a US with a contrast harmonic and also perhaps a fine needle aspiration. The last studies about this case showed that aspiration needle of 19 gauge was able to have a histology specimen in 93% and also to achieve a KI 67 diagnosis in 86%. And with a very good correlation with the surgical specimen. So I pass to room 3 with Professor and Dr. Santo and Arcidiacono.
Yeah.
Okay, so I was just saying at the start that we are in the neuroendocrine mood today. And this also represents the situation that we are seeing more and more incidentalomas because this patient is clearly asymptomatic and not related to the symptoms that he might have. So there is a lesion in the tail. We are here in the pancreatic tail area, which is quite non-homogeneous, and we are looking for the lesion. We have just started the examination. The patient wasn't so stable at the beginning, but in the meantime, this is the splenic vessels. I cannot see a clear lesion here.
Sometimes the lesions are very high in the very distal part
of the pancreas.
So it's on the tail. So we, in this case, here it is. So we have to do in this. This also stresses that if you want to see the tip of, if you want to be sure that you saw the tip of the tail, you have to go to the area of the hilum of the, you have to go to get to the hilum of the spleen, and then you turn a little bit to the left and then you see the pancreatic tail. So this is the lesion, which Paolo has already characterizing with the elastography. Yeah. And if we stop that, let us see. It looks like a mixed to the stiff lesion.
Yeah.
Huh?
Yeah. Sorry. Voila.
Okay.
Okay.
But still, it didn't change. It didn't change.
It didn't change too much because your scrolling was perfect.
Okay. Yeah. So, but you also look at the.
Sometimes in this area you can find
splenosis, splenic accessory spleen. Yeah.
This is an hypo and big accessory spleen.
Yeah,
sometimes, but you have to take in your
accessory
mind.
spleen can mimic a small neuroendocrine
lesion. This is a different diagnosis also in the pancreas itself.
Sometimes you have
splenosis in the pancreas.
Inside the pancreas. Tissue, yes.
So
but anyway, you see that the lesion is not very vascular by regular Doppler.
Yeah. Okay.
It was a little bit stiff, so we go over for the sonoview. We go for the sonoview. Okay, so now I think we can inject.
Yes.
Paolo.
We can inject.
Yeah. Tell me.
Paolo.
Yeah.
Can
Could you
inject?
it was very nice demonstration of how you cleaned up the image there. Could you just tell everybody what you did?
Oh yeah, we just
that's
clean.
an example of you knowing what you're doing, but not doing things.
Yeah, because usually they clean everything. So you see now there is the injection.
So the injection is here. So you see very nicely the enhancement that we have, that we're getting.
Can you see? Can you see the injection and the hyper enhancement of the lesion and the very early arterial phase like before? Nick, can you depict that?
Yep.
Yeah. So
nice.
we have just cleaned the images, just reducing the gains of the different area in the focus.
So what happens sometimes if somebody touches the when they clean the instrument, so they move it, you have to take care.
Yeah.
Okay, but anyway, we saw this enhancement.
Yeah.
Then we can switch back, I think, to the regular view, and we can go, and we can also see what Adrian said before, that we can apply a regular Doppler. Now you can see better. You can see better the vessels inside that we didn't see at the initial study, so we can see it very nicely now. We are now preparing for the FNA. I chose the 22 gauge needle, Procore needle again, because I think I have a better chance to have some core in one pass, and also it will be quicker. We check as routinely with a color Doppler just to see that there are no vessels, and then we are getting into the lesion. Up. Here we are, just a second. No, I'm not happy with that. Now. It's better now. Yeah, it's moving this.
Yeah,
it's
typical like for the
neuronocran. Yeah, it's
very
yeah, but I
slippery.
think we are inside. I think it a little
maybe,
bit
on the edge of the lesion probably.
Yes, but still I think no. I won't take any chances. So let's get back. Let's get back. Okay. This is sometimes these lesions will look very simple, and
yeah, because sometimes when you are like in this position and with the quite like in a J maneuver is seems to be the movement of the lesion is
where we are in, but we don't see the needle so well, but I think we are in. For sure we are in. But this is the tip. Yeah. Just the tip of the needle. Yeah. Now we are better. Sometimes you see that I can do these quick movements without any risk to go beyond where I want to go, because I'm stopping the movement of the needle with my hand, not with the stopper. So I think we can remove and apply suction. I usually use suction, not the slow pull technique.
In any case?
Not in any case, but for example, in lymph nodes or other lesions, no problem. But here, we will wait a few seconds. Usually we wait for 30 seconds just to let the tissue get into that groove. And then we do a few movements, and then we are done. So I think we can go now.
Okay.
Okay.
Thank you, Erwin.